What my charge is over the next 40 minutes or so is to give you a broad overview of treatment of metastatic breast cancer with emphasis on things that are new, bringing in things from San Antonio and elsewhere, and then trying to give you some sense of whether that data has affected the guidelines in any way. So the topics that I'm going to discuss are listed on this page. We're going to talk a little bit starting out with endocrine therapy and some of the newer strategies for overcoming endocrine resistance. We'll talk about some markers that can be potentially utilized to determine early whether the therapy you're utilizing is effective. Touch on the emphasis of rebiopsying at the time of recurrence at least once. We'll talk a little bit about anti-HER2 therapy, and then finally, somewhat perhaps seeming incongruous with the topic, discuss mastectomy in patients with metastatic breast cancer based on data that was recently presented from 2 large trials. So we'll start out with a case. A 67-year-old woman presents with progressive metastatic breast cancer involving bone and lung. She had been diagnosed many years ago with stage 2 disease, which was hormone receptor positive, HER2 negative. She had a right-sided lumpectomy and radiation therapy and subsequently received AC-fall by T-dose stents and then endocrine therapy for a full 5 years. She remained free of disease and no symptoms until recently when she complained of bony pain, and an evaluation at that point revealed that she did indeed have bone metastases as well as a couple of small liver lesions. Her labs were otherwise normal. Her performance status, with the exception of the rib discomfort, was pretty good, and her physical exam showed no abnormalities. So you have the audience response clickers in front of you. Would you rebiopsy prior to starting systemic therapy in this patient? So most of you would, and a minority would not, and we'll talk a little bit about that because I think at least at one point, as the data would suggest, there is a small fraction of such patients that will have a change in their markers, either for technical reasons or biologically or reflecting the heterogeneity of the disease, and as such it may influence the therapy you use. In addition to a bone strengthener, be it zoledronic acid or denosumab, would you recommend systemic therapy with capecitabine, eribulin, tamoxifen, fulvestrant, or the combination of exemestane and everolimus? So sort of a mix across the board, a lot of folks focusing on endocrine therapy, and we'll talk a little bit about that. Small fraction considering chemotherapy, and I'm not suggesting there's one right answer that's applicable to everyone, but of course you have to look at the patient in front of you and make a judgment about the pace of the disease, their overall medical condition, comorbidities, et cetera. All that goes into play when you're making a decision. But in this particular case, with primarily bone disease, limited visceral disease, endocrine therapy would not be unreasonable. And then finally, do you use circulating tumor cells as a way of determining if systemic therapy is providing the desired effect earlier, sooner than the typical scan interval? So the majority would say no, a fraction say yes, and we'll look at the data that's been recently presented to see if that strategy is helpful. So this is what the guidelines more or less look like with respect to endocrine therapy for patients with stage 4 disease. You've seen this before, and basically the message that comes through is that in the appropriate patient, you continue endocrine therapy until there's evidence of clear refractory disease, or you've exhausted the number of options for endocrine therapy, and at which point you may consider chemotherapy as the reasonable next step. But endocrine therapy, because of its toxicity profile, has often been viewed as the optimal treatment for ER-positive breast cancer as long as you're not in visceral crisis. If you look at the timeline for new agents over the last couple of decades, the thing that's readily apparent is sort of there's a drop-off around 2002. We haven't seen much of anything that's been added in terms of anti-hormonal therapy in the last more than a decade. And if you look to the horizon, it's not as though we have a bunch of things that are new that are coming along. But that said, and we'll get to the issue of how do you overcome endocrine resistance, the real strategy is what can we add to endocrine therapy to either enhance its effect or overcome resistance, and that reflects the approval of everolimus in 2012, and we'll come back to that in a moment. So these are the agents in the guideline. Again, what we'll suggest as we go through some of the data is there's not necessarily an algorithm or a sequence that is always optimal. We have to, again, look at the patient just as we would with chemotherapy, make a decision. There are those that, rare patients where you can go through every single one of these, and Ken Osborne has often made the case in those rare patients you can even come back to the notion of recycling some of these agents. And I would be the first to admit that's not very common that we have the luxury of doing that. But we do have a lot of endocrine options, and then those with very indolent disease, we can go through many of these and stretch out the duration of therapy over a period of many years. So without going through all the data supporting the notion that AIs are good, tamoxifen is good, fulvestrant has had some data, I want to revisit some of the topics that we thought we knew the answer to many years ago. And if you go back a couple of decades, combination endocrine therapy was more or less abandoned because we had better single agents with good tolerability, and the original observations with giving things like aminoglutathamide and other drugs in combination with such agents really failed to demonstrate any improved efficacy, but it did show that you got greater toxicity. So not unlike the story with chemotherapy, putting things together doesn't always necessarily improve outcome, but it usually does increase the side effect profile. So what is the data? So looking at some of the more recent trials, anastrozole plus or minus fulvestrant in the so-called FACT trial from about a year and a half ago, in postmenopausal patients or those that were pre and then made postmenopausal who had previously been treated with an AI in the adjuvant setting, they either received anastrozole alone or anastrozole plus fulvestrant. And if you look at the time to disease progression, there's pretty much no difference between the lines. It looks like there's no advantage to the addition of the second agent, fulvestrant, above and beyond anastrozole. And similarly, if you look at overall survival, no added advantage. Now, it's important to know that the FACT trial failed to demonstrate any benefit, whereas there was a SWOG trial with almost 700 patients where PFS was improved. Now, you could question whether the advantage of that, I always wanted to use this. So you could really question whether that advantage is clinically relevant, but it was statistically significant. And similarly, when you look at overall survival in the SWOG trial, there was an advantage to the combination. But I think an important thing that has to be realized is when you look at the data from the SWOG study, it was really in patients who were naive with respect to prior tamoxifen therapy. So if you're an advocate of combination endocrine therapy, you have some data, limited as it may be, to suggest that combination could work, but most of the data fails to support a marked improvement in outcome. And it does, again, limit you because you have one less agent you can use if you've already used it in combination. So for most of us, although it is suggested in the very tiny font in the guideline that this could be done, the data is pretty limited. Now, what about patients who have gotten therapy after progression on a prior AI? Well, the first three trials I'm just going to sort of mention in passing and really leading up to the notion of combining endocrine therapy with newer targeted agents. The EFFECT trial, which I was involved in many years ago, was an example that really demonstrated the sequence didn't make a whole lot of difference. These were patients who had previously gotten an AI, and then they were randomized to fulvestrant with a loading dose or exemestane. And as you can see on the bottom, whatever endpoint you looked at, including toxicity, everything was superimposable. So one interpretation is the trial failed to demonstrate any benefit. The alternative is that you could do anything in this setting, and it would be a very reasonable thing to do. The outcome was quite the same. So you have to make a decision. Is a patient more suitable for a PO medication or something that you might be more worried about compliance and you give them an IM shot? The question of dosing has long been addressed with fulvestrant because we knew long ago, 15, 20 years ago, that an IM shot with 250 milligrams just barely got to the clinically effective steady-state level, and the limitation was how much of this drug could you actually put in somebody's backside to effectively get there. But 500 milligrams was compared to 250 milligrams, and as you know from the data, there was an improvement in PFS. The clinical benefit rate was somewhat higher, and based on these results, 500 milligrams became the new standard if one is using fulvestrant on a monthly basis. And then the SOPHIA trial, again, an exercise in looking at whether combination therapy in patients who had already been exposed to an AI, in this case either getting exemestane, fulvestrant, or the combination of fulvestrant and anastrozole in postmenopausal women who'd already progressed on a nonsteroidal, as you can see, failed to demonstrate any significant difference between the groups. So all of this data would suggest that we have lots of endocrine agents. So trying to tell you that one sequence is better than another is really not supported by the data. Now, where the interest really lies, and again, you go back 25 years, if we thought in our very simplistic way, we'd put a diagram up, there'd be a little estrogen receptor sitting somewhere on the surface or in the nucleus, and then estrogen would come migrating in, and then you give tamoxifen and everything would stop, and that was the end of the story. And obviously, even this diagram is meant to be simplistic, but it does emphasize that we have a lot of signaling pathways and a lot of crosstalk between pathways. And what's been demonstrated in many different models, preclinically as well as in patient biopsy samples, is that we see hyperactivation of some other pathways in patients who become endocrine resistant. And in particular, the one that is gained the most interest in the endocrine arena is the hyperactivation of the PI3 kinase mTOR pathway, and this has become something that is both druggable and targetable, as you know, and as a result, clinical strategies to look at whether or not you can overcome endocrine resistance have gained a lot of interest. So the TAMARAD study, published a few years ago now, was the first that really hinted that by targeting mTOR that you could overcome endocrine resistance. This was a small phase 2 trial, only about 100 plus patients in those that had already been treated with a nonsteroidal, and they either got tamoxifen or the combination of tamoxifen and the mTOR inhibitor everolimus. And I think what was remarkable is that if you look at the clinical benefit rate and the time to disease progression, there was almost a doubling, particularly with respect to TTP for those who got tamoxifen and everolimus, suggesting that there was an impact that really was clinically meaningful. And this was followed by the much larger and more definitive Bolero-2 study, which appeared in the New England Journal of Medicine and presented by Jose Bazelga, again looking at postmenopausal patients who had been refractory to either letrozole or anastrozole, and they were randomized to exemestane. The basis for that trial design is we know there are a small fraction of patients who get nonsteroidal AIs who will respond to a steroidal AI. So they were randomized to either exemestane or the combination of exemestane plus everolimus. And again, if you look at the overall response on the left and the clinical benefit rate on the right, patients in lavender who got the combination or doublet of everolimus plus exemestane clearly had a superior outcome. Now, again, if you look at some of the Lancet papers and many other publications that have tried to molecularly characterize tumors using a variety of different laboratory methods, we've come to appreciate that there are a lot of driver signaling pathways that are mutated in the different subsets of breast cancer. And as it's germane to this part of the talk, I just draw your attention to the ER-positive group as opposed to the right triple negative or those that are clinically HER2 positive. And it's striking the fraction of tumor samples that had PI3 kinase mutations as well as P53 mutations, and then as you can see a very long list smattering of all other kinds of driver mutations that might be important. So because as a result of these findings, a lot of the clinical trial design is now trying to look at whether one can target some of these other pathways in combination with endocrine therapy. So I think going forward, as the mTOR experience in the Bolero trial and the Tamarack trial suggests, it's all going to be about who's your dance partner, what is endocrine therapy going to be combined with. And to that end, there are a variety of different strategies, not just focusing on PI3 kinase or mTOR. There are CDK inhibitors that are in trial, as you well know, cyclin-dependent kinases that are very important in cell cycle progression. There's a Pfizer drug that's far along in development that targets CDK4/6, and preclinical and clinical studies supporting an interaction between it and endocrine therapy. Excuse me. The phase 2 trial that has been presented and really is the basis for all the enthusiasm for the ongoing phase 3 trial is shown here, in which patients with ER-positive, HER2-negative metastatic disease were randomized either to letrozole or letrozole plus the CDK inhibitor. It was a two-phase trial, and the second phase really tried to enrich patients with either loss of P16 or amplification of CCDN1, which ended up not really being all that important. But if you look at the collated results, what it suggests is the patients who got the doublet in blue of the CDK inhibitor plus letrozole versus letrozole alone had a pretty remarkable improvement in PFS, which the lines demonstrate and numerically look even more impressive, 26 months versus 7.5 months. Obviously, this is a randomized phase 2 trial with all its limitations, but nevertheless, it did show a pretty remarkable difference, and this is what's really pushing the phase 3 trial that's underway. Similarly, if we go to the recent San Antonio meeting, a drug that we wouldn't necessarily think about in any way as it relates to breast cancer, dasatinib, has also been combined with letrozole. And this is a trial that was, again, a smaller experience, and whether it'll be pursued in a much bigger trial, I think is still open to discussion. But the target of dasatinib, although it's pleiotropic, is clearly looking at SRC. And SRC has been shown that when combined with aromatase inhibition, you get greater breast cancer inhibition than with either strategy alone. And it's also interesting, and probably one of the more remarkable findings that come out of this particular small trial experience, is that by blocking SRC, you may actually have some impact on bone density, a plus in patients who are getting aromatase inhibitors. And I think for this crowd, everybody knows that dasatinib is not a drug that we use for breast cancer, but it is approved for CML, and there is preclinical data suggesting that you may get an additive effect with some other endocrine agents. So in this particular experience, these were patients who were ER positive, who were allowed to have had an adjuvant AI, and they could have gotten treatment for metastatic disease with chemotherapy, but not receive an AI in the metastatic disease setting. And this is what the trial looked like: letrozole alone or letrozole plus dasatinib given on a daily basis. And as we would expect, and what we've seen also in the Bolero trial with mTOR inhibitors, when you use a combination of an endocrine agent with something else, particularly a targeted agent, you start to pick up some of the toxicities that aren't so familiar to endocrine therapy alone. So in this case, you start to see a little bit more rash, a little bit more edema, fatigue, etc., which you might not expect, of course, with letrozole alone. The clinical benefit rate between the two, the doublet or letrozole alone, was very much the same. But if you look at the time to disease progression or progression-free survival, again, we see this suggestion that by giving a doublet of an agent that enhances the effect of an endocrine agent, and you may actually translate it into an improvement in PFS. And that was, again, very similar to what we see with the CDK inhibitor, and not unlike what we see with the mTOR inhibitor, a doubling of the time to PFS. So these are the sort of strategies that we can see on the horizon, not so much the next aromatase inhibitor, the next anti-estrogen, but how do we put these drugs together with other targeted agents. And the very interesting finding from this trial is if you looked at the beginning of the trial and looked at baseline bone mineral density, the percent of patients with a T-score less than negative 1.5 on the left, they're fairly similar between the two, but once the patients are on study, the patients who got letrozole and dasatinib had a marked improvement in bone density, so you didn't see that drop. So there is a biologic effect on bone density that inhibition of SRC does confer. Now, would you biopsy the patient that we talked about at the outset? This was a patient who is now 7 years post-diagnosis, had some bone disease, not always an easy target, but also had a couple of liver mets of about 1 centimeter in dimension. I think everybody's familiar with this sort of cascade of data that we've seen over the last several years, both at ASCO and San Antonio, suggesting that there are the development of discordance between the primary and metastatic disease, between the primary and the time of disease recurrence. And there were large pooled analyses that were presented a couple of years ago at ASCO with just under 300 patients. And the important finding was that you see discordance between the primary and recurrent disease anywhere from 13 to 30%. With ER/PR, a smaller fraction of patients have changes in HER2. And if you look at 22 studies that were collated for the educational book, I think the bottom line is, regardless of the methodology used, IHC, FISH, CISH, et cetera, you see discordance rates anywhere between 0 and 38%. So although one wouldn't necessarily biopsy every time the patient recurs, I think it's prudent, particularly if there's some time between the original diagnosis and disease recurrence, if you have a site that's readily biopsiable, so to speak, that you go after it to make sure the markers are consistent with the original diagnosis. It may either cause you to add something that you not necessarily would, or delete something that you were planning on using. How do we know the treatment is working sooner rather than later? And this gets to the issue of whether we can rely on anything other than scans gotten on 3 to 4 month intervals. So to that end, there was a trial that was presented at San Antonio just a few months back that looked at the issue of whether circulating tumor cells would be useful to that end. And keep in mind that we've known about circulating tumor cells for many years now. We've known that if the number's going up, probably not a good thing. If they're going down, maybe it's a good prognostic sign. But the real issue is, can you use that information early on to change therapy, and by extension, doing that, will that in some way impact on overall outcome? That's the ultimate thing you want to be able to say. So the SWOG trial looked at patients with metastatic breast cancer that was measurable or non-measurable, including the bone. They had no prior chemotherapy for metastatic disease. Their HER2 status was known. And this is what the trial looked like. CTCs were drawn at baseline prior to first-line chemotherapy. Those with a very low CTC count, less than 5, were monitored for PFS and overall survival. It's really the patients who had a rising or a higher circulating tumor cell count above 5, and they were drawn after the first dose of chemotherapy again. And at that point, patients who had a continued elevation of their CTCs above 5 were randomized to maintain the original chemotherapy that was planned at the outset. So they would just continue whatever was going on right from the beginning. Or because that CTC count, 3 weeks after the start of chemotherapy, was still elevated, they were switched to an alternative therapy. So the notion underlying this is that by somehow changing therapy early on the notion that your current therapy is not effective, you're going to impact on overall outcome. Did that turn out to be the case? Well, the answer is no. So overall survival by randomized arm, whether you got the same therapy continued or whether you switched very early on because of an elevated count, made absolutely no difference in terms of overall survival. Progression-free survival was also identical. So I think at the present time, using CTCs as a surrogate for or as a measure of whether your therapy very early on is effective is probably not supported by the data, and I wouldn't do it. So what's new in chemotherapy, making the transition to that? Now this, of course, could be a topic for an entire hour discussion as it relates to breast cancer, but as it's germane to the topic I was given, I would submit this: not much. So we're not going to say a whole lot about chemotherapy, and it's not because I don't think chemotherapy is effective or it's a foundation for many of the patients we use, that we treat, but if the topic is what's new in chemotherapy as it relates to breast cancer, metastatic breast cancer, the answer is not much. So you're all familiar with the menu of drugs that we have available. It is a long menu, which is a good thing. You can get into the debate about whether combination therapy is better than single agents. For most patients, sequential single agents is effective. It gives you more options and is not necessarily in any way inferior to combination therapy. So I think with that, I've now exhausted my discussion of chemotherapy for metastatic breast cancer. So one topic I did want to touch on is this notion here that despite changes, we still have paclitaxel bevacizumab in the guideline. And that's based on the clinical trials that were done, and though the FDA has altered their recommendation about this, we still think that it's a reasonable thing based on the data to have it selectively available for patients with metastatic disease. And it does appear with an explanation in the small font below the guideline, based on the trial results we have, that this could be considered. Where we typically use it, if done at all, is in patients who are younger, triple-negative disease, usually first-line therapy for metastatic breast cancer. And if they don't benefit from it there, we don't continue it or add it on later. Is there anything new with respect to anti-angiogenic strategies for metastatic breast cancer? There are a variety of drugs in clinical trials different than bevacizumab that are trying to determine if there indeed is an effect. The closest we come to any new data that might apply is the ramucirumab data, which was recently presented by John Mackey through the ROSE trial, which was combining ramucirumab with docetaxel in patients with metastatic disease. And ramucirumab is an antibody that affects the VEGF2 ligand. So docetaxel alone or docetaxel with ramucirumab, patients were continued until disease progression. These were patients who were HER2 negative, and they could have gotten no prior chemotherapy for advanced disease. And these are the results. And although difficult to see, what's apparent is that there is no statistically significant difference with the addition of ramucirumab to docetaxel with respect to progression-free survival. And certainly with an early look, the interim analysis, no added benefit with ramucirumab to docetaxel on overall survival. So again, this would suggest that at the present time, we probably haven't made a great advance forward, at least with this particular drug. You do find that overall the time to progression, although might be a little less with the combination, again, there's not a huge difference. So I would submit that at least as it stands in 2014, we haven't moved the ball all that far upfield, at least with anti-angiogenic strategies we currently have available. Now, anti-HER2 therapy, which is, again, a very broad topic, I just want to sort of quickly summarize because, of course, within this group of patients, which is a modest fraction but significant fraction of breast cancer patients, we've had a lot of activity, a lot of drug development in the last couple of years, and it actually continues with newer drugs being evaluated for those patients who've progressed beyond pertuzumab, TDM1, et cetera. So there's still a lot of activity in this arena. I think the good thing is that the frequency of patients with HER2-positive metastatic breast cancer is probably declining, and that's a function of the use of anti-HER2 agents in the adjuvant setting. And we've seen the outcome of those patients, and we saw that many years ago now with the pivotal trials from the cooperative groups clearly showing that anti-HER2 therapy has caused a reduction in the number of patients who do recur. But they still do. And we see what's happened because of anti-HER2 therapy. At the top, you can see that in the absence of anti-HER2 therapy in patients who were HER2 positive, their one-year survival was about 70%, which was not so different than HER2 negative patients a few years back. And now with treatment, including trastuzumab, we've seen that the overall survival is markedly improved. So we're having more effective therapies in this arena, and it's really because of a better understanding of the biology. If you look at all the trials that have, and this is sort of the beginning of the story, of course, the original Slayman paper and then the Marty paper, one with paclitaxel, the other with docetaxel, chemotherapy with or without trastuzumab, and if you cut to the chase at the bottom, Both experiences, which really launched this whole arena, showed a significant improvement in overall survival when trastuzumab was added to chemotherapy. And this is even in the context where crossover was allowed. So it was a very real effect on a really hard, important endpoint, overall survival. And then over the last many years, every chemotherapy we've had has been combined with trastuzumab. And I'm not going to subject you to going through every single phase 2 trial that's ever been done with navalbine, capecitabine, gemcitabine, et cetera. And what's clearly been demonstrated is that there doesn't appear to be added toxicity when chemotherapy is added to trastuzumab over what chemotherapy alone would show. And in many of these cases, preclinical models show that there would be synergy, and indeed, in most of the clinical trials, you see synergy, greater anti-tumor effect than you would see with chemotherapy alone. The only new thing, and so I can draw chemotherapy into this discussion somehow, is there was data presented with eribulin, perhaps the most recent newly approved drug in metastatic breast cancer, not so new anymore. And as is true with all the other trials that have been reported, when you place eribulin with trastuzumab in patients with HER2-positive metastatic breast cancer, you do get a greater effect than you might see with eribulin alone. So a small trial, 52 patients, 40% of the patients had a prior HER2 therapy in the adjuvant setting or elsewhere. And importantly, and not surprisingly, you see a significant objective response rate with the combination of eribulin and trastuzumab. So my only point is to emphasize, as is true with everything else that's been done in the last decade, if you combine anti-HER2 therapy, specifically trastuzumab, with chemotherapy, and in this case, the newer drug that we have around, eribulin, you see a similar effect. You do buy a bit more in the way of side effects, obviously, with eribulin. The peripheral neuropathy was seen. You do see neutropenia and fatigue. So again, the side effects that you would expect with that particular drug. Now, where we are with some of the newer therapies and our strategies are based on the introduction of next-generation anti-HER2 therapies. The trial by Bazelga with the Cleopatra study looked at patients with HER2-positive metastatic breast cancer, the combination of trastuzumab and docetaxel, or the triplet of pertuzumab, trastuzumab, and docetaxel. And I think everybody appreciates that pertuzumab is an antibody that prevents heterodimerization of her family members. And as a result, it has a different epitope than trastuzumab, and there is synergy when you put the two together that you wouldn't expect with either alone. So the results from the Cleopatra study showed a significant improvement in both PFS and overall survival, favoring the triplet. And because of these results and not an excessive amount of toxicity when the third agent was added, this became sort of the go-to first-line therapy for HER2-positive metastatic breast cancer. And again, you can follow the Kaplan-Meier curves out, and the patients who received triplet therapy had a better overall outcome at each time point that was determined. Not to be so rigid that one would stick with docetaxel as the only partner for trastuzumab and pertuzumab, the Memorial Group looked at combining those same two antibodies with paclitaxel in a phase 2 experience, which is shown here, a trial of about 70 patients, which essentially demonstrated the same findings, that if you combine pertuzumab, trastuzumab, not with docetaxel, but with paclitaxel, the vast majority of patients had an anti-tumor response, whether they were getting it as first or second-line therapy. And similarly, there was no excessive amount of toxicity that was unexpected over what you would see with paclitaxel alone. So as a result, when the guideline committee met, we felt that we shouldn't be so rigid that we would say it must be docetaxel, but rather a taxane plus pertuzumab and trastuzumab would become the preferred first-line therapy for HER2 metastatic disease. And then along came TDM1 in rapid succession to pertuzumab. Everybody now is familiar with TDM1, which is essentially a cytotoxic link to trastuzumab. A stable linker was always the problem in developing these fusion molecules in the past, but now with a stable linker, you eliminate some of the toxicity that was seen in previous generations of fusion molecules. This is the maytansine is not getting free of the linker and causing undue systemic toxicity. So the Amelia trial was presented by Kim Blackwell and published by Sunil Verma. looking at a comparison of TDM1 to capecitabine and lapatinib, which at the time would have been viewed as a very reasonable second-line therapy after patients progressed on trastuzumab. So these are patients who had gotten prior taxane and trastuzumab therapy. And as you know, progression-free survival favored TDM1 over capecitabine and lapatinib, and the overall survival was similarly favorable to the doublet of to the TDM1 over the doublet of capecitabine and lapatinib, and furthermore, the toxicity profile also favored TDM1. So again, if you look at all grade adverse events, importantly, there wasn't a cardiac signal that suggested that either treatment regimen was associated with significant drops in LVEF. If you look at the fraction of patients who discontinued therapy, it was far fewer in those getting TDM1 than getting capecitabine and lapatinib. So on balance, it seemed to be not only more effective, but better tolerated. And then the Teresa study, which was presented, really looked at patients with HER2-positive disease who had gotten significant prior therapy for advanced HER2-positive metastatic breast cancer. They'd gotten trastuzumab, they've gotten lapatinib, and gotten a taxane. They, in a model of the eribulin approval, were randomized to TDM1 or treatment of physician's choice. And what was actually demonstrated, and this sort of gives you the sense that these were patients who had got significant prior therapy, a small fraction who had had brain mets, that patients who were getting treatment with TDM1 had a better outcome than patients who received treatment of physician's choice. Where this is all going in the metastatic disease setting is really centered on the Marianne trial depicted here, a trial of about 1,100 patients where randomization is between taxane and trastuzumab, TDM1, or the combination of TDM1 and pertuzumab. So again, these are trials that are moving these drugs up front, and as you know, again, not the topic of the discussion today, we also have these drugs entering into the adjuvant arena. The Affinity trial, which looks at the combination of pertuzumab, trastuzumab, has already completed its accrual. We expect that to be reported sometime probably in 2015 or 2016. So these drugs are moving up closer in the algorithm for treatment of metastatic, for adjuvant therapy as well. And the only side note I would mention is we talked earlier about mTOR inhibition and how that might play in endocrine therapy. There was a trial presented by Ruth Regan at ASCO last year, the so-called Bolero-3 trial. There was a succession of Bolero trials all looking at mTOR inhibition. In this case, it was trastuzumab vinorelbine plus or minus everolimus. There's some preclinical data to support the notion that by giving an mTOR inhibitor, you might enhance the effect or overcome HER2 resistance. And although this was statistically significant, favoring the triplet, 7 months versus, basically 6 months, I think a lot of people question whether it's clinically relevant. And as such, we have not included this in the guideline, at least at this point. All right, so let's move on to a case, a different case. This is a 55-year-old female who presents with a large breast mass that has been progressively enlarging for the last year. The patient's last mammogram was 4 years earlier. She has no other history. Her physical exam reveals a large 3-centimeter mass occupying the upper left quadrant of a large breast. There were no skin or nipple changes. A 1-centimeter axillary lymph node is palpated. The remainder of her exam is normal. The mammogram confirms the finding on the left. She's found to have a ER-positive, PR-poor, HER2-negative breast cancer by biopsy. Because of the long history, large tumor, it was elected for her to have staging exams, which revealed that she had around 3 lung nodules, multiple liver lesions consistent with metastases, and lab work revealed normal chemistry and liver function, and she ultimately did have one of the liver biopsied, confirming that it was indeed consistent with metastatic disease. So would you initially perform a mastectomy on this patient with de novo metastatic breast cancer? So the majority say no, about 20% say yes. would you treat with endocrine or chemotherapy initially? Good, so there's consistency. If you're not operating, you're doing something. So with respect to, I think that's the last answer. So I would say no to mastectomy at the outset, and we'll talk about that in a bit. I mean, there are exceptional cases. Patient has a fungating lesion. She's got a lot of symptoms. It may not, based on what we know today, change the overall survival, but it may be the most prudent thing for long-term care of the patient to consider mastectomy or some sort of local surgery to ameliorate symptoms. And, of course, we would give systemic therapy to somebody who's never been treated for metastatic disease. So why would one consider primary surgical therapy in patients with stage 4 disease? Well, there's some data, actually a lot of data that's been collated, almost all of it retrospective, that suggests that by performing a mastectomy in a patient with de novo metastatic disease, that you may have some impact on overall survival. And of course, this is supported and mirrored by similar experiences of taking the primary out in other diseases and other malignancies that suggested that you might have an impact. There have been a whole number of trials that have been, or I should say not trials, but reports conducted over the last decade, and they're collated here and shown in sort of a forest plot that suggests resecting the primary tumor in women with stage 4 disease is associated with longer survival. And if you actually look at the hazard rate, reduction in survival or improvement in survival of about 30% is suggested for patients who undergo a mastectomy with de novo metastatic disease. But all kinds of caveats. It's retrospective. It is selective. It's all kinds of things that go into different size experiences. So to that, we now have 2 trials that were recently, actually trials, not reports, but trials that have been reported addressing this question at the San Antonio meeting in 2013. The Indian trial, the Tata Memorial Center trial, randomized patients with stage 4 metastatic breast cancer at presentation who had gotten anthracyclines plus or minus taxane, so one might argue more conventional chemotherapy. And if they responded with either a CR or PR, went on to local regional treatment or no local regional treatment. So these are patients who are getting systemic therapy that have to demonstrate a response. Importantly, we don't know anything about the HER2 status in these patients, and anti-HER2 therapy was not part of the treatment. If you look at the overall results from survival in this trial, it made absolutely no difference. The lines are superimposable. And if you go out 2 years, similar effect, the overall survival is no difference between those who got local surgical therapy or not. And the time to first distant progression was statistically different, but if you look at the endpoint of overall survival, there was no difference. So the patients who had no local regional therapy actually seemed to have a better outcome than those that did not. So I told you that already. The second trial is the Turkish trial, presented in tandem at the San Antonio meeting. And this trial design is somewhat different than the Indian trial. This is a trial of patients with stage 4 breast cancer. They are randomized to get systemic therapy or initial therapy with surgery and then systemic therapy to follow. So in contradistinction to the Tata trial, where patients had to respond before they even went on to a consideration of surgery, the randomization was from the get-go here. The chemotherapy was ultimately given to all patients in this trial, and similarly, patients also received endocrine therapy, and bisphosphonates were also given. So this is what the number of patients in the trial look like. About 300 recruited, an equivalent number ultimately who got systemic therapy from the outset or initial local therapy followed by systemic therapy. If you look at overall survival, there was no difference between the 2 groups. It had no impact on overall survival. Similarly, if you look at ER positive and ER negative disease, the overall outcome was identical. There was no statistical difference. Even if you look at patients who are HER2 positive and HER2 negative, there was no statistical difference. If you look at patients who had triple-negative disease, we start to get into smaller numbers of individuals, but no statistical difference between those who had local therapy at the outset or systemic therapy to begin with. And if you look at bone-only Mets versus all other Mets, again, no difference between the groups. Even though this looks like there might be a difference, it is not statistically significant. And the only group where there seemed to be some suggestion were in those with so-called solitary bone metastases, where surgery on the primary from the outset seemed to make a difference. Importantly, these are patients that did not get that solitary bone met biopsied, so we don't even know that it was breast cancer. So I think, again, we don't have data based on the most available trials to suggest that a standard should be in de novo metastatic disease to perform surgery on the primary tumor. And similarly, looking at young or old made no difference. So what I would suggest to you, based on this sort of survey of where we are, is there's a lot of activity going on in the endocrine arena of treating breast cancer, not so much with the development of new anti-hormonal therapies, but rather utilizing those that we have and combining them with targetable, druggable signaling pathways that are important in development of resistance. And we've seen evidence of that with the mTOR inhibitors. We have the CDK inhibitor coming along, and I suspect there will be PI3 kinase inhibitors as well. CTCs do not seem to serve as a surrogate for getting imaging or a means to change therapy earlier with the expectation that you'd have a better outcome. I would still submit that at some point a patient with metastatic disease should get rebiopsied if possible, particularly earlier than later. This may alter the therapy that you use. We have a whole variety of anti-HER2 therapies, not only to utilize in the metastatic disease setting, but as you well know, by FDA approval, we can now use some of these in the neoadjuvant setting, and shortly they will become utilized widely in the adjuvant setting. And then finally, mastectomy in metastatic disease, I think, can be done selectively, but it should not be a standard for de novo metastatic disease. And even though I didn't talk about chemotherapy to any great length, I think the menu of drugs that we have available represents a number of different options for patients. And there still are drugs being developed, but in the last year, there's nothing new that I can really add that isn't already represented in the guideline. So with that, I'll stop, and if there are questions or comments, I'd be happy to address them. Thank you.